Bismillahirrahmanirrahim. Now we are going to start the anti-diabetic drugs. So first we look at our learning objective. So in our learning objective, we should be able to classify the different categories of anti-diabetic drugs and identify their mechanism of action, pharmacokinetics, pharmacodynamics of each class of anti-diabetic, and identify their clinical uses and their side effects, contraindication, and the indication. So these things should be considered in the anti-diabetic drugs. Okay. So before we start the antibiotic, review some concept related to your carbohydrate metabolism, because the diabetes is one of the problem in the carbohydrate metabolism. You know better, the glucose is the one of the digested component of carbohydrate. Carbohydrate is a polysaccharide and the glucose is the monosaccharide. Because we take our meal in which the nutrients are present in the polysaccharide form. So in the intestine, they are digested into the monosaccharide form, because monosaccharide form is important for the absorption across the intestinal wall. So the glucose is monosaccharide, so the carbohydrate break down into the simplest form to absorption in the blood. So these are some general concepts. When the glucose enter into blood, after that they enter into different tissues. We have GLUT 1, 2, 3, 4. Okay, and you know better, the GLUT 1 and 3, they are present in the RBC and the brain, while the GLUT 2 is present in the liver and the GLUT 4 is present in the muscle and the adipose. But important thing is that only GLUT 4 is the insulin dependent. Okay, so which is present in the muscle and the adipose. So if there is the absence of insulin secretion, so what will happen? Your blood glucose level will be increased. If there is resistance to insulin action, then there will be blood glucose increase, because the GLUT 4 is under the control of your insulin. So if there is low insulin, or you can say there is resistance to their action, so eventually what will happen? The blood glucose increase. So if there is absence in secretion, so we call it the type 1 diabetes. If there is resistance to insulin action, so we consider it the type 2 diabetes. Okay. And the other thing you should consider that regard 99% glucose is reabsorbed via your renal tubule. Okay, or especially proximal tubule via SELT2 and SELT1. Okay, but we should consider especially the SELT2. What is SELT2? Sodium glucose cotransporter. Okay, which is present in the nephron. So if the blood glucose increase, what will happen? We call it the hyperglycemia. So our urine glucose will increase. So we name them the glycosuria. So these are some general concepts associated with your carbohydrate metabolism. Let's compare the diabetic mellitus type 1 and the type 2. Type 1 is the juvenile onset, okay, because they occur in the early age, before the 35-year age, and they are less common. In the only 10% cases are associated with the type 1. So we name the juvenile because they are early age, while the type 2 that occur after the 35-year and they are most common. 90% cases are associated with the juvenile. So it's simple. Sometimes you confuse which occur in the early age, which occur in the later age. So you can simple type 1 if in early age, type 2 later age. 1 come first, the 2 come later. Okay. And what is the problem? The lack of the functional beta pancreatic cell. Okay. So as there is lack of the functional beta cell, what will happen? Lack of insulin secretion. So your persistent glucose level will be high. And it's the autoimmunity associated with this problem is associated with autoimmune or better. Most of the time there is autoimmune antibodies which actually destroy the pancreatic beta cell, so which is responsible for the lack of the insulin. So this is problem in the type 1, and so that's why they require the insulin to survive. So we consider in the type 1 diabetic as insulin dependent. Okay. And if you look at the type 2, where you see some beta cell are functional, but there you can say abnormal insulin secretion. So, but the major issue is the resistance to the insulin action due to obesity or genetic factor. Most of the time, you can say 85 to 90% cases associated with the obesity is for you can say in the etiology for the type 2, and some cases are associated with the genetic factor. But you should consider the genetic factor is associated with the type 2, not associated with the type 1. Okay. And in the early stage, we start with the first line therapy is the metformin. So we should consider some diet regulatory, follow the diet regulatory chart and the exercise. But it's in the early stage. We can give the drug because some beta cell are functional. Okay, but in the advanced stage where you can say all the beta cell become dysfunctional, then this type 2 become insulin dependent. Early on they are non-insulin dependent, and later they can become the insulin dependent. Okay. So if you look at some clinical features, so which help you identify the type 1 diabetes, they are usually present young, thin, and acute onset patients, and they have diabetic ketoacidosis. Why ketoacidosis? Because when there is low glucose in your tissue, so the energy level go down. So in order to maintain the energy level, so our body try to produce the ketone body. So in this way, one of the clinical features in the type 1 is the diabetic ketoacidosis, and there is severe insulin reduction. You can better. Okay. And in the characteristic feature in your type 2, they are usually old patients, and they have slow onset and no diabetic ketoacidosis, abnormal insulin. Okay. In the later, they can be present with if there is advanced stage diabetic ketoacidosis occur, but in the early stage there is no diabetic ketoacidosis, and their onset is slow while they are acute onset. Okay. And if for the insulin there is abnormal insulin, we can take out the insulin level by the C-peptide, which is helpful for to measure the insulin. And what are the diagnostic criteria to define if the diabetic patient or not? Okay, if the random plasma glucose level crosses the 200 mg per deciliter, and fasting blood glucose crosses the 126. So for the proper diagnostic, so you should consider at least 2 the fasting blood glucose where the level increases crosses the 126 mg per deciliter. And other is you should check out the postprandial glucose level, which if you given the 75 gram oral glucose, and postprandial means after the meal. Okay, it also crosses the 200 mg per deciliter. So you can check out after the 2 hours if it crosses. And these are also considered, but the very important is the HbA1c. If their saturation is more than the 6.5, then you should consider it a diabetic mellitus, because the HbA1c give the data for 2 to 3 months of your glucose level in the blood. Okay. So based on these diagnostic criteria, you can go for the treatment of the diabetic. Okay. So what are the therapeutic strategies? Of course, we start with the lifestyle changes to decrease the plasma glucose, and if there is uncontrolled, then you go for the anti-diabetic drug. Okay. So we are in this lecture we are associated with the type 2 because the insulin is associated with the type 1. So majorly we are discussing the oral and the subcutaneous drugs associated with the treatment of type 2 diabetes. Okay. So in the lifestyle changes, proper dietary management, you should follow. The patient should follow the dietary chart. Okay. And where they should decrease their caloric intake, and decrease their weight, because if it's especially in the obese, because obesity is most of the common presentation in the type 2 diabetes. Okay. And they should increase the physical activity. If you recall your physiology or biochemistry, where you know better the GLUT4. GLUT4 is actually stimulated by either the insulin or by the exercise. When you increase the physical activities or the insulin level, so they will increase the GLUT4 upregulation. Okay. And in the anti-diabetic drugs, so there are actually 4 categories. One is the insulin secretagogue, which actually increase the insulin secretion. Other is the insulin sensitizer, means they increase the sensitivity of insulin, or you can say they decrease the resistance of the insulin. Okay, and these are associated with insulin secretion. Other are associated with the glucose absorption and the reabsorption. So one drug with alpha glucosidase inhibitor, which decrease the glucose absorption, and the SELT2 inhibitor, they decrease the glucose renal reabsorption. Okay, so these are 4 categories. 2 are associated with the insulin, means one increases the insulin level, other increases their sensitivity, while the other 2 are, one is decreasing the glucose absorption, other is decreasing the glucose renal reabsorption. Okay. So we have 4 categories: insulin secretagogue, insulin sensitizer, alpha glucosidase inhibitor, SGLT2 inhibitor. In the insulin secretagogue, we have sulfonylurea, magnetide, incretin, and DPP4 inhibitors. In the insulin sensitizer, we have vagonide, we have thiazolidine, and the amylin analog. So in the alpha glucosidase inhibitor, we have acrobose or the megalotol, while in the SELT2 inhibitor, there are gliflozin, dapagliflozin, canagliflozin, empagliflozin. Although I am going to explain their mechanism separately, so just overview picture is coming here. So we take the food in a complex, forms complex carbohydrates. They're broken down into glucose by the alpha glucosidase. What is alpha glucosidase do? This is actually the Bruce butter enzyme in the intestine. Okay, so which actually break the alpha 1,4 bond. Okay, so they break the carbohydrates into the glucose in the intestine. Then the absorption of glucose occur from the GAT and enter into the blood. Okay, so in this way they increasing the blood glucose. Other thing, there will be maybe a renal reabsorption. They can increase the blood glucose via the SGLT2, especially I'm mentioning here. Okay, so in this picture, actually, I'm trying to show what are the sources, the component which increase the blood glucose, what are the component which decrease the blood glucose. Okay, so you can say either from the diet blood glucose can be increased, or either by the renal reabsorption blood glucose can be increased. In the glycogenolysis or gluconeogenesis in the liver, or the glycogenolysis in the liver and muscle both, so they can increase the blood glucose, and the blood glucose can be decreased either the tissue uptake where the glycolysis occur, and by the glycogenogenesis in the liver and muscle. So these components actually decrease the blood glucose, while all these components are going to increase the blood glucose. Okay, insulin do what? Insulin actually stimulates these uptake pathways, and they inhibit these the glycogenolysis or gluconeogenesis pathway, which actually going to increase the glucose level. Okay, so while glucagon do opposite, so they inhibit the uptake pathway and the inhibit the glycogenolysis and the gluconeogenesis. Okay, so insulin secretagogue do what? They actually increase the level of insulin, and the insulin sensitizer do what? They actually increase their activity, or you can say decrease the resistance over the tissue. Okay, so these are the action of the insulin secretagogue and the insulin sensitizer. While the alpha glucosidase inhibitor do what? Like acrabose or maglitol, so they inhibit the alpha glycosidase. So they inhibit the dietary uptake of your glucose. Okay, so because no monosaccharide, no absorption. While gliflozin, they inhibit the SGLT2. 90% of your renal reabsorption of glucose occur via the SGLT2, while the 10% occur via the SGLT1. Okay, so they are inhibiting the SGLT2. So these are the summary of all your mechanism. So if you look at the action of some insulin just adopted from your medicine book, so glucose uptake increase, and the glycolysis and the glycogenous synthesis is going to increase by the insulin protein synthesis and the uptake of ions. So these are stimulated by insulin, while the gluconeogenesis or glycogenolysis, lipolysis, ketogenesis are produced. These are inhibited by the insulin. So let's start with the sulfonylurea. So just look at, because they are increasing the insulin secretion. So recall the concept of the insulin secretion, how the normal physiology say this insulin secretion. Let's look at the pancreatic beta cell. So here is pancreatic beta cell. This is outside, inside. Okay, here is the insulin. It is stored in the vesicle. Okay, it's inactive. Pro-insulin form. Okay, so let's look at what is happening here. Here are the two channels. One is the calcium channel, through which calcium enter into the cell, and the other is the potassium, the ATP potassium sensitive channel, through which potassium go outside and cause the hyperpolarization. Normally this hyperpolarization occurring, which actually inhibit the calcium channel. So there is no calcium entry in the normal case. When you take your meal, so glucose enter via the GLUT2. Okay, so because you know that GLUT2 is present in the liver as well as in the pancreatic beta cell. So glucose enter into the cell, and they, after the metabolism, they produce what? ATP. So this ATP is actually inhibitory over this potassium, the ATP sensitive potassium channel. Okay, as they inhibit this, mean there will be no hyperpolarization. Okay, mean potassium will remain inside the cell. They cause the depolarization. Depolarization actually stimulate the calcium channel, so they cause the opening of this voltage gated calcium channel. So calcium entry occurs. So this calcium entry is responsible for the exocytosis of the insulin. Okay, so in this way you can say the calcium is responsible for the release of insulin. So here is by the ATP. Okay, so and the sulfonylurea or their meglinitide, they do what? They actually increase the insulin secretion by inhibiting this potassium channel. Okay, so sulfonylurea have different receptor sites. Okay, while the meglinitide have different receptor sites. So their mechanism is similar. So they inhibit this you can say potassium channel and cause the depolarization, which is responsible for the entry of the calcium, which causes the insulin release. Okay, So in the mechanism, block the ATP sensitive potassium channel via the specific receptor for the, you can say, sulfonylurea, the sulfonylurea receptor. So they cause depolarization and opening of voltage dependent calcium channel, and which increase the intercellular calcium in the beta cell, which increase the insulin release. Okay, so but you should know this point. If it's non-effective in totally insulin deficient patient, meaning if the beta cell are dysfunctional, then there will be no effect of the sulfonylurea, because if they are partially functional, so they can increase the insulin secretion. Okay, if it's dysfunctional, then the sulfonylurea and meglinitate, they become ineffective. Okay. So here are some concepts you can recall from your hypertensive drugs. So the thiazide diuretic and the minoxidil or the diazoxide, they actually do what? They actually stimulate this potassium channel. So they cause the hyperpolarization. Mean hyperpolarization, no calcium intake, no insulin release. So that means they cause what? Hyperglycemic. So we call them the diabetogenic. Okay. So they compete with the, you can say, sulfonylurea and the meglinitate. So if someone is taking these drugs, so in this situation, you should increase the dose of the sulfonylurea or the meglinitate in order to make them effective. Okay. So let's look at the sulfonylurea. We have actually first generation and second generation. In the first generation, we have tolbutamide, so acetohexamide, tolizamide, chloroproramide. So they end with the amide. So these are first generation. Well, the tolbutamide, this is short acting, while these other three are the long acting. Okay. In the second generation, the glycoside or glyphoside. So these are the short acting, and while the long acting glyburide or the glimepiride. So these are the long acting, their half life is 12 to 24, while in the short acting they have 10 to 16 hours half life. So just for mnemonic, we call it long ride. Okay, so they are long acting, long ride. Okay. So why there is first generation, why there is second generation? First generation have some problems. So there is accumulation of the parent drug and the metabolite. As they accumulate, so they cause the hypoglycemia. There is higher risk of hypoglycemia because they are accumulated in your body. So they are showing their effect for the longer period. So there is higher risk of hypoglycemia. While in the second generation, they have some beneficial points. Number one, they are more potent, mean less dose is needed, and they have longer duration of action, and they are less frequent dose are needed, and have fewer adverse effects as compared to the first generation. So that's why the second generation is preferred over the first generation. Okay. And if you look at the pharmacokinetics, so they are all the oral drugs, so orally well absorbed, and they reach their peak concentration into 2 to 4 hours. And all are the highly bound to plasma protein, mean their volume of distribution is low. Okay. And duration of action is variable, either it's a short acting or the long acting. And then metabolism occur via the liver. So if a liver disease patient, so there is high risk of the hypoglycemia. So they increase the adverse effect because no metabolism. So what will happen? This will accumulate in the body, which cause the hypoglycemia, or you can say other adverse effect like weight gain. They are excreted via the urine. So in the older patient or in the renal disease, so there are higher risk of the adverse effect even in small dose, because no excretion, there will be accumulation. So hypoglycemia or weight gain side effect will be more probably occur. Okay. So in the CKD, in the chronic kidney disease, avoid you amide and ride. Amide are the first generation, and these amide and the ride, these long acting of the second generation. So you should avoid these drugs because they have active metabolites, so there is higher risk of the hypoglycemia. While so what you should choose the glyphoside, which is the short acting second generation. So because their half life is unaffected by the decreasing the GFR, and so there is less risk of the hypoglycemia. Okay. And they can cross the placenta and cause the fetal hypoglycemia at birth. So because the mummy is the diabetic, the fetus is not the diabetic. So if they cross the placenta, so they can cause the fetal hypoglycemia. Not only the fetal hypoglycemia, so there are other some teratogenic effects. So that's why it's contraindicated in the pregnancy. Okay. Most of the oral hypoglycemic, they are contraindicated in the pregnancy. So our drug of choice in the pregnancy is mostly the insulin, but nowadays metformin is also considered, but most usually the insulin is preferred. Okay. Now, if you look at the clinical use, of course, diabetes mellitus type 2 as a monotherapy or in combination with other. So depending upon the condition, if it's adverse, there is a higher the blood glucose, then you go for the combination. Okay. So then because they increase the insulin secretion via beta cell, which will decrease the blood glucose. And but the important thing is if you are continuously using the sulfonylurea for the longer period, there are higher risk of the failure of the beta cell, because there is progressive linear decline in the beta cell function. Because in this way, because you are using more and more pancreatic beta cell, means you are exhausting the beta cell. Okay, in the advanced stage, there will be the failure of the beta pancreatic cell. Okay, and the other important adverse effect, one is the hyperinsulinemia and hypoglycemia, especially with the long acting. Okay, it's understandable. So especially in the older patients or in the old age, and the hepatic or renal disease patients. And the weight gain, if they not follow the diabetic diet, or you can say exercise. What is the problem in the sulfonylurea? Because when someone is taking sulfonylurea, their appetite level will be increased. Okay, so as the appetite increase, they eat more, there will be more lipogenesis. Okay, this is number one mechanism. And the other mechanism is that if a obese patient have low level of glucose in the tissue, okay, so the body try to compensate the energy level. So they actually start the lipolysis, so which actually decrease your weight. While if someone is taking the sulfonylurea or any the drug which control the diabetes, what will happen? The glucose enter into tissue, and after the energy demand is maintained, so what will happen? They start the lipogenesis. So in this way, they are responsible for the weight gain. Okay. So advantages, they are once daily dosing, and their immediate benefit, well tolerated, well characterized, and one of the other important advantages is the inexpensive. The most inexpensive drug in the all these oral, or you can subcutaneous, is the sulfonylurea. So that's why most of the time most patients love to use the sulfonylurea. But there are these side effects you should be considered. In nutshell, they are decreasing the fasting plasma glucose and the HbA1c. So here are some indications for the sulfonylurea. If there is non-insulin dependent type 2 diabetes, okay, after the failure of diet regulation and exercise, you can use the sulfonylurea. And the other indication, if it's in mild diabetes, when there is insulin requirement is less than the 30 units per day. Okay, so and especially in the non-obese patient, so it is contraindicated in the obese patient. In the non-obese, because sulfonylurea increase the appetite, so they contraindicated for the obese patient. Okay. So another thing is the non-complicated diabetes. If there is no stress, no major organ disease. Why no stress? Because when there is stress, what will happen? Your body increase the glucocorticoid production. So glucocorticoid compete with the insulin action. Okay. So in the stress condition, you should choose the insulin instead of the sulfonylurea. Okay. So stress like infection or operation or any pregnancy. So these are contraindicated in the stress situation. And if there is no major organ disease, because they can cause hypoglycemia, no history of diabetic ketoacidosis. If there is diabetic ketoacidosis, means your beta cell are almost you can say non-functional. And what will happen? There will be that's why there is a high level of keto. So that's why the sulfonylurea are ineffective. Lack of sufficient insulin increase the ketone to meet the energy demand, and sulfonylurea do what? They actually increase the risk of hypoglycemia and worsen the metabolic imbalance in the diabetic ketoacidosis. Okay. And the other important usage for the chloropropamide in the diabetic insipidus. So this is not associated with this mechanism. There is other mechanism. They actually potentiate the ADH. Okay, and the nephrons, so they act as anti-diuretic. What is problem in the diabetic insipidus? Polyuria. So they actually they act as an anti-diuretic. So that's why they are useful in this condition also. But there are some other adverse effects which I am not mentioning in the last picture. So here are some other which is not difficult to memorize, because there is mnemonic A, B, C, E, D, F, G, H. So A for allergy, hypersensitive and cross allergy with the other sulfonamide like thiazide, and the bone marrow inhibition. B, C, polycystic jaundice, and D, dysphospholipid like action, because there is alcohol intolerance. Okay, and there is edema due to anti-diuretic effect. And the failure in primary failure means 10 to 15% of non-insulin diabetes dependent, and there will be a secondary failure after the long usage of you can say the sulfonylurea. Okay, and the GAT disturbance like heartburn, NVD. NVD means what? Nausea, vomiting, diarrhea, and there is increased incidence of the coronary heart disease. So, but the important thing is that these B, C, D, E, F, those are mainly associated with the chloropropamide. Okay. So overall contraindication for the sulfonylurea is the type 1 diabetes because there is dysfunctional pancreatic beta cell and the non-insulin dependent if there is stress period. Okay, so because there is high level of glucocorticoid, so that's why you go for the insulin instead of the sulfonylurea. And if in the pregnancy and lactation because of teratogenous and the hypoglycemic side effect, so that's why they are contraindicated. If there is history of diabetic ketoacidosis means because they increase the hypoglycemia and the person the metabolic imbalance. Okay, and if there is severe hepatic and renal disease because there will be a drug accumulation which causes hypoglycemia. So this is all about sulfonylurea. Let's look at the meglinitide. So meglinitide, only one drug which is considerable, that is the repaglinide. So this is rapid acting as compared to the sulfonylurea, mean their 4 hour, their half-life is only 4 hours and there is short duration of action. So this is actually taken prior to the meal. Okay, so I consider it's a pocket drug. Mean whenever someone go for a meal, so he should take the repaglinide. Okay, and their mechanism identical sulfonylurea, but their receptor and differentiate as I mentioned already. So and the pharmacokinetics orally well absorbed, very fast onset of action, just reaches the peak in 1 hour, and the metabolism is in the liver excreted in the bile, not by the renal. So you can say it will be the drug of choice in the renal disease patient if because you should avoid the sulfonylurea in the renal disease. Okay, especially the long acting. And taken just before each meal, if someone is taking 3 times meal, so he should take 3 times. If he is taking 4 times or 5 times, so every time he take meal, so first he should take the repaglinide, and if he skip any meal, so he should skip the dose. Okay, so dose should be skipped if the meal is missed. If he take the dose, there will be risk of the hypoglycemia. So clinical use, type 2 diabetes, if someone is allergic to sulfonylurea because there is sulfur in their structure of the sulfonylurea, so someone are allergic to that, and if there is a renal disease patient, so you should use this drug. Okay, in monotherapy or in the combination for the, you can say, advanced stages. In the early stages there will be the monotherapy. Okay, adverse effect, although weight gain and hypoglycemia, but they are less than your sulfonylurea. Okay, so there are some other very important things. They are for their metabolism. The enzyme are the cytochrome P450 family 3A4. Okay, so if someone is taking their inhibitor or someone taking their inducer in the inhibitor like ketoconazole or fluconazole, erythromycin, so these are inhibitors of this enzyme. So they will increase the duration of action of the drug. So there will be higher risk of the hypoglycemia. Okay, when someone is taking the inducer like barbiturates or carbamazepine or rifampin, so they decrease their duration of action, mean they make them the ineffective. Okay, so there is decrease in their effectiveness of this drug. So in the nutshell, they are decreasing your postprandial glucose, they are decreasing the fasting plasma glucose, and they are decreasing the HbA1c. So these are all understandable. Postprandial because we are taking with the meal, and they are decreasing the fasting plasma and the HbA1c. Okay, so let's look at the incretin mimetic and the DPP4 inhibitor. What is incretin? These are actually the GAT hormones. Okay, especially GLP-1 and the GAT. GLP-1 means glucagon-like peptide 1 and the gastric inhibitory peptide. Okay, so what is their action? They actually after the eating, they actually increase the insulin level. Okay, and they decrease the glucagon level. So by inhibiting the alpha cell and stimulating beta cell, increase the insulin. Inhibiting alpha cell decreases the glucagon. So both things will decrease the blood glucose. Okay. This is their level increase after the eating. So other time there will be they are inactivated by DP4 enzyme, which normally inactivate them. Okay, so when you give the incretin mimetic, mean they are increasing the insulin level and decreasing glucagon. So in this way they are beneficial. So other DP4 inhibitor, mean they inhibit this enzyme, so they prevent the inactivation of the incretin. So in this way, both way they are increasing the incretin action. Okay, so in this way they are helping in the lowering the blood glucose level. Okay, so glucagon-like peptide increase insulin and decrease the glucagon, where we have liraglutide or dulaglutide and exenatide. So they end with the tide, TIDE. Okay, while these are the mimetic, these are the DP4 inhibitor, dipeptidyl peptidase, peptidase 4 inhibitor, which increase insulin and glucagon. Here we have gliptin, sitagliptin and vildagliptin. Okay, their mechanism of action increasing insulin, decreasing glucagon, decreases the blood glucose. Okay, so in the nutshell, they are actually decreasing the postprandial glucose because their their secretion occur after the eating. But this secretion actually occurs even there is your glucose level is not elevated as you start the meal, because it takes time to elevate the blood glucose level. So as you start eating, so there will be the increased level of incretin, so which will increase the insulin. As the glucose is coming into blood, they are going into the tissue. As they come into blood, they are going to tissue. Okay. So they decrease the postprandial glucose and they decrease the HbA1c. Okay. So here is just look at then what is the effect of the incretin. So if you look at here on this side there is insulin release, on this side there is time. So here is the IV glucose. If someone is taking IV glucose, so this will be the insulin release. Okay. If someone is taking the oral glucose, so this will be the insulin release. Why there is the increase in the insulin release in the oral glucose? Because of effect of your incretin. So this effect means someone taking the IV glucose, because there is no incretin, so there is less release of your insulin. While someone is taking oral glucose, there will be increase the insulin release. Okay. So this is a healthy person in the type 2 diabetic. There is actually what is problem in that type 2? There is IV glucose, on this side there is a oral glucose. You can see there is low level of insulin release because of the decrease in incretin effect. So that's why the incretin mimetic or DP4 inhibitors are the beneficial. Okay. So they increase the incretin effect, so they increase the insulin level. So mimetic, so these are drugs, and they also decrease the actually appetite. So in this way they inhibit the body weight gain. Okay. So their pharmacokinetics, they are given subcutaneously once a week, and they come in the single dose pre-filled disposable pens. Okay. So they are coming in a disposable pen, so only use once a week. Okay, subcutaneously. And clinical use diabetes mellitus type 2 with the diet and exercise, and because they increase the insulin and decrease the glucagon, which decrease the blood glucose, but they are contraindicated in the type 1. Okay, because if you increase the incretin level, they are affecting the pancreatic beta cell. While in the type 1, there is a dysfunctional pancreatic beta cell. Okay. Obese are overweight. In the overweight, we use liraglutide, because if someone is obese and having any of these problem like obesity with the diabetes type 2 or the hypertension or the dyslipidemia, so our drug of choice is liraglutide, because they are on the one hand they are decreasing the you can say the blood glucose, and other hand they are decreasing the weight. Okay, so decreasing glucagon, decrease the appetite, decreasing the weight gain. Okay. And in the adverse effect, hypoglycemia, when if you combine with the sulfonylurea or insulin, because there will be higher level of the insulin, which can cause the hypoglycemia. As alone, there is not much problem associated with the hypoglycemia, not associated with the incretin mimetic. Okay, nausea, vomiting, and diarrhea, of course, because this is most common because they are going into your gut. Okay, pancreatitis, because they are affecting the pancreas and the loss of appetite and arrhythmia. And there is higher risk of the medullary carcinoma of thyroid. So that's why they are contraindicated in the medullary MEN2. MEN2 is what? Medullary endocrine neoplasia type 2, where you have the neoplasia of the multiple endocrine glands like the thyroid, or you can say parathyroid, adrenal. So that's why they are contraindicated in this condition. Okay. So in the nutshell, there is postprandial glucose decrease, HbA1c, DPP4 inhibitors. So these are the drugs. So pharmacokinetics, they are given orally once a day. Okay, their higher half-life 8 to 14 hours. Okay, their clinical use diabetes type 2, but the patient should follow the diet and exercise. Okay, and our combination with the other, they are not used as alone most of the time. So they increasing insulin, they are decreasing glucagon, we decrease the blood glucose. Okay, adverse effect, nausea, abdominal diarrhea, of course, the nasopharyngitis mean what? Running nose. Okay, and the headache, joint muscle pain. So these are some side effects with the DP4 inhibitors. So in the nutshell, they are decreasing postprandial glucose, decreasing the HbA1c. This is all about the insulin secretagogue.